Okay, my name is Anna Winters, and thank you so much for joining today's ICT4D Malaria Elimination Conference. You have joined the panel titled Power of Geospatial Data for Malaria Elimination. Like I said, I'm Anna Winters, and I will be hosting the panel today alongside a number of colleagues and collaborators from Johns Hopkins University, PATH MASEPA, Malaria Consortium, and USAID CDC President's Malaria Initiative. So I want to say thanks so much for joining. I think we'll have a great conversation, and we have some fantastic panelists with us today. So before I introduce the panel, what I'd like to do is just give a quick introduction to our conversation. And this really focuses on the world of geospatial data, which really has exploded over the last 10 years. Expansion in the number of digital devices and availability, the availability of satellite imagery, the decrease in cost, the improvements in spatial modeling, AI acceleration, and an increasing urgency as a backdrop towards impact and innovation and pushing the needle towards malaria elimination. So harnessing the power of geospatial data at the country level is key as we progress towards malaria elimination. For those of you that are not malaria epidemiologists in our audience, malaria is a vector-borne disease. It's spread by mosquitoes, Anopheles, and the transmission of malaria relies heavily on a number of environmental characteristics that largely rely upon place. For example, various mosquito vectors rely on specific habitat profiles. These can sometimes be seen through space detected by satellite imagery. And using different, what we'd say, spectral signatures, we can start to understand the areas of highest risk of infection. Then if we know where people are living, where are those populations, and we can start layering that type of data in a geospatial platform, we can start to understand which areas are most likely at the greatest risk of transmission in order to strategically deploy and even target our interventions like indoor residual spray, malaria bed nets, or others. So in order to expand this just a little bit further, and then I'll go back to introduce our panel, I'll bring to you an example, and I'm calling this the John Snow Broad Street Pump Thinking. And we're bringing this example to malaria. If you're not familiar with the story of the Broad Street Pump, this is a story that is crucial in the textbooks of epidemiology. The Broad Street Pump was the epicenter of a cholera outbreak, and someone named John Snow drew crude maps to help define the location of that cholera outbreak and that pump that was really the epicenter. So I want to bring to you this quick picture and figure from Alagana et al. A paper in Nature that really helps to give a picture of how we can simply use geospatial data to help understand the nature of malaria transmission. So if you can look at figure A here, this is, imagine a map of a health facility catchment. You can see the households there, the breeding habitat for malaria vectors, the swamp, the marsh. That area may sustain malaria transmission and result in what we would call focal transmission or hotspots of infected houses. And sometimes these hotspots are located far from health facility catchments. And you can start to see in figure B there, a spatial model that was developed to depict the probability of seeking healthcare as a function of distance of household to those vector breeding spots. And then if we want to bring in another data stream, you can see point C. This is a model where remotely sensed satellite imagery was used to understand where high degrees of vegetation and potential risk areas. So these various data streams were combined into a gridded spatial model that you see in D. And this spatial model predicts the incidence by month that's highlighted, these population areas that could be targeted for specific interventions and active surveillance. So you can see this as a picture of, as we bring in a geospatial context these various data streams together, we can better understand where's the highest risk of transmission, how can we be best activating community health workers in the surveillance context, how can we best target and deploy interventions, how can we best deploy sometimes limited health intervention resources. And again, the idea of these geospatial data providing us that power. So today we'll hear from Dr. Matt Murphy, Kafula Salumbe from PathMasepa, Dr. Arancha Roca from Malaria Consortium, and Dr. Bill Moss from Johns Hopkins University. I will give each of those individuals a fuller introduction as we move forward. So first, I'd like to introduce Dr. Matt Murphy. He is with the U.S. President's Malaria Initiative Center for Disease Control. He has a PhD in environmental health and a master's in entomology. Prior to joining CDC, Matt focused his efforts on investigating interventions for vector control and supporting surveillance data systems in Kenya and in the Gambia. In the past 16 years, Matt has worked for the CDC, where he's led public health and malaria efforts through both Africa and Asia. Matt has lived for 5 years in Ethiopia. He has provided efforts as the PMI Strategic Information Lead, where he supports PMI in-country teams and ministries of health to optimize the use of malaria-related data to help guide interventions. So with that, I'd like to introduce Matt. Matt, feel free to go ahead and start. You've got about 7 minutes, and I will go ahead and progress the slides for you.
Great, thank you, Anna. Good morning or good afternoon, everyone. Thank you for the opportunity to speak with you today. Next slide. I am the CDC Strategic Information Team Lead with the U.S. President's Malaria Initiative, commonly referred to as PMI. So the PMI program started in 15 African countries, but now works in 24 partner countries in sub-Saharan Africa and 3 countries in the greater Mekong subregion of Southeast Asia. And these countries represent approximately 90% of the global malaria burden. PMI is a multi-agency initiative led by USAID and implemented with the US CDC. Next slide, please. PMI has recently released our strategic plan for 2021 to 2026. Key overarching program priorities within the new strategic plan include 5 focus areas. These are reaching the unreached, where we seek to achieve, sustain, and tailor use of high-quality, proven interventions with a focus on hard-to-reach populations. Strengthen community health systems with the goal to transform and extend community and frontline health systems. Keep malaria services resilient by adapting malaria services to withstand external events such as COVID-19, emerging biological threats, and climate change. Invest locally with the goal to better partner with countries and communities as they lead and implement malaria activities. And innovate and lead where we want to leverage new tools and optimize existing tools. These are long-term PMI priorities, and it's clear that high-quality geospatial data is necessary to achieve these objectives. PMI activities are based on implementation of evidence-based interventions, and we understand the need to be efficient and effective to use these funds to achieve maximum malaria control and elimination goals. From a program perspective, the use of geospatial data to combine location, temporal, and attribute information is integral to the future of PMI to better assess malaria risk, inform the implementation of new interventions, and assess the effectiveness of current malaria interventions or activities. So some examples of current and future use of data include increased tailoring of subnational interventions within countries based on data, identifying the locations of health facilities and community health workers to help assess if populations are being reached, mapping malaria services available at different locations to answer questions such as where can an individual seek ANC care, testing and treatment for malaria or receive immunizations, or where are interventions being implemented, such as indoor residual spraying, distribution of bed nets, and entomological monitoring, and improving data quality and strengthening surveillance systems by use of digital tools. Next slide, please. So we have a great group of panelists who will be discussing specific case studies in depth, but I did want to briefly highlight some current examples where PMI has used geospatial data. Every year, each PMI country conducts an in-depth operational plan where we finalize activities and budgets for the next year. This first slide shows a basic example of how mapping PMI and partner activities can help programs see potential gaps in coverage and identify areas in need. The red stars also help to visualize the location of therapeutic efficacy studies, so a type of research, to serve as a useful communication tool when discussing these TES sites. Next slide, please. So this slide shows another example, though I admit that this visual may be a bit chaotic, but even so, when it comes time to make decisions about resource allocations, this level of detail can be useful to assess how to optimize malaria activities, often being conducted by different partners that geographically overlap. This represents a high-level mapping of indoor residual spraying, surveillance and monitoring activities, case management, and bed net distribution activities. Also, by comparing this mapping of activities to a country stratification map, we can discuss if interventions are being targeted in areas of the most need and where they can make the most impact. Next slide, please. This slide shows the stratification map from a few years ago, illustrating the malaria burden in Ethiopia. I lived in Ethiopia for 5 years with PMI, so thank you in advance to any Ethiopian colleagues that may be in attendance. The stratification map is very useful as we plan resources to target the high-risk populations through IRS, ITN, and SBC activities. So I know this is the elimination conference, and the use of geospatial data is equally as important in targeting elimination areas. So the image on the right shows how early in the elimination planning process, geospatial data was used by the Ministry of Health to create a strategy that addressed subnational elimination goals in phases, using these maps to strategically identify elimination districts and roll out new elimination policies and resources. Next slide, please. This slide shows an example of a project in Guinea where data was used to map mosquito breeding grounds to guide potential environmental modification activities. Next slide, please. So lastly, a component of PMI's long-term vision for data use, I want to briefly describe the MDive platform that the PMI program developed to serve as a tool to compile, house, analyze, and visualize data from PMI countries. The platform incorporates many types and sources of data, including monthly data reported from countries to MDive on a quarterly basis. The MDive platform includes interactive dashboards, such as those shown on this slide, which illustrate district-level epidemiological, supply chain, climate, and financial data across 27 PMI countries to help form a comprehensive view of malaria trends and resource allocation for decision-making. Next slide, please. The platform serves as a potential tool for PMI to visualize data trends and resource needs across regions. In this sample screenshot, users can visualize malaria burden and look at trends over time. MDive users have their choice in how they want to visualize the data. Data can be chosen within the tool by diagnosis, such as suspected malaria, confirmed malaria, or malaria deaths, mapping by 1 or 2 admin levels, chosen by a particular time frame, or can be narrowed down to a distinct location within a country if you have a particular area of interest. Next slide, please. This slide shows a sample dashboard comparing confirmed cases with the levels of rainfall. Other examples of dashboards include an elimination dashboard, which contains an overview of elimination metrics across PMI countries, including information on testing, incidents, and prioritized elimination districts. There's also supply chain dashboards where users can look at logistics reporting, quality, stockouts, and consumption of commodities. So I will wrap up my portion of the presentation. Thank you for your time, and I look forward to our discussion.
Thank you, Matt. I appreciate it. We will reserve some questions towards the end. Let's move ahead. And I'd like to introduce Kafula Salumbe. He is the Zambia team lead for PATH MASEPA. Kafula is an experienced public health specialist. He has a demonstrated history of working in health programming, planning, implementation for 18 years. Kafula is skilled in epidemiology, health economics, planning, budgeting, and epidemic preparedness. He is a strong program and project management professional with an MPH focused in public health policy from the University of Arizona. I'd also like to say we have had a long working relationship, and I'm very happy that you're here to join us, Kafula. Why don't you go ahead? You've got about 6-7 minutes.
Thank you very much, Anna, and greetings to you all as I take you through my portion of the presentations today to just give you an experience of what we have had in Zambia working with geospatial data in guiding malaria interventions and activities within the IRS space, the indoor residue spraying program within the NMEC. Next slide, please. So just to put things into context, MASEPA Zambia has been working in the country since 2005, and we have been working in collaboration with the National Malaria Program over the years, testing different approaches and strengths of malaria data, leveraging new partners as well as current partners to see how we could scale up work within the country. And of course, we have invested quite a bit of our time and resources into granular geospatial data over the years to ensure that we have good quality data coming into the program guiding decision-making going forward. Next slide. So just building on to what I've just mentioned, we have been working on various campaigns within the country and mainly around the indoor residue spraying campaigns, as I mentioned. But we have built core geospatial data layers to help inform malaria program planning, which then enhances micro planning and service delivery to all the delivery points within the healthcare delivery system of malaria intervention. And then, of course, with that, we have ensured that capacity is built within the health facilities, districts, and even the communities with regards to decision-making around the geospatial data tools that we have deployed. And one of these key tools is the mobile tool itself that we have been using with field teams to improve effectiveness in achieving high coverage to reach the last mile. And then, of course, once this data is collected, we ensure that the analysis is done to identify any gaps or any issues that need to be addressed as rolling out is done to ensure there's maximum impact and improve policy making based on the data that is collected. Next slide, please. So I will just provide two examples of what we have currently done in Zambia, one specifically around spatial data use in planning, and then secondly, an example on achieving effectiveness through mobile technology. Next slide. So this is one of the maps that was generated from the previous campaign, the currently 2021 campaign that we just completed in the country. So this is a district called Gwembe, where we geo-spaced the whole district in terms of targeting where spraying should be done and where ITNs will be deployed within the district. Next slide, please. Yes, so this is just a more granular perspective with regards to the map that was previously shown. So if you look at the map, you clearly see there are yellow and green dots. So the green dots indicate the households that were actually reached during the spraying. And the yellow dots indicate the structures that were targeted but were not reached. So this information will be key in terms of where improving and where targeting should be better placed, given the resources that are available going forward, because some of the challenges associated to reaching these structures are of course embedded in the teams as they're going around. So having this information collected from those local levels will be able to guide where we can then deploy all the necessary interventions, not only around indoor residue spraying, but also other interventions that could be pertinent for household level interventions. Next slide, please. So the second example basically focuses on mobile technology. So the use of the Reveal tool that we have been supporting with our partners across has helped us to ensure that we help in the terms of navigation of the teams that are deploying the various activities within the local areas where they are spraying in the southern part of the country and western part of the country, where we have been rolling out this intervention. And then with the Review tool, the in-field accountability is enhanced because it prevents data collectors from selecting a household unless they're within 25 meters of that particular structure. So in terms of reporting on whether these actual households have been visited or structures have been visited, accountability is enhanced because you're able to track virtually how the teams are moving around the various locations where they're operating from. And of course, online coverage tracking is also enhanced because data collectors can see the houses that have been sprayed and those that have refused the spraying and what next steps could be taken. And just to also mention that with these tools in place, we have two versions of the Reveal tool itself. You have the light touch Reveal, which basically ensures that teams visit areas that are prioritized during planning. And then we have full Reveal, which basically ensures high coverage within operational areas in the priority districts. So basically giving you two types of approaches depending on the resources available to ensure that you have a basic tracking system that captures the work of the teams as they are navigating the intervention areas. Great, so this basically builds on an overview of how the data is looked at once it's collected. So if you look at the two graphs, basically it gives you what the Review platform then relays as information collected on the ground. So you look at total structures that are in that particular area, and of those structures, how many are targeted, and of those that are targeted, how many were actually visited, and of those that were actually visited, those that were actually sprayed. So this gives you an indication of where the loss was made, where you can clearly see the red arrows, as well as where you need to ensure that next time when you're planning for a campaign, you focus on those areas where you did well and ensure that you concretize those, and those areas that you were not able to reach, you are able to re-strategize on whether you really need to go ahead with the same intervention or same strategy, or look at a different intervention altogether. Next slide, please. So the key takeaway points from this are that three in total they have. The first one is right spatial data helps decision makers to more accurate resource allocation. Of course, when you know where your problem is based on the spatial data, you'll then be able to allocate and target interventions accordingly. And then secondly, putting data in hands of the frontline health workers as close to the communities and people that you serve allows for efficient and effective campaign decision making. And lastly, mobile tools are very essential tools for microplanning to effectively carry out and help maximize impact for the money that has been spent on any campaign that is conducted on the ground. And for that, I end here for my presentation and hand it back to Anne. Thank you very much for your attention.
Thank you, Kafula. Fantastic presentation. Appreciate it. There may be in your Q&A side, if you click on that, Dr. Murphy, there's a couple questions posed at you. I think you can type in some answers there for the audience, and then those that we don't get to, hopefully we can get to during the panel discussion. So at this stage, let's move onwards. Dr. Arantxa Roca is joining us from the Malaria Consortium. So thank you so much, Arantxa. Arantxa is a PhD malaria epidemiologist. She trained at the Liverpool School of Hygiene and Tropical Medicine. She's got 15 years of experience in both malaria control and elimination in countries across Africa and Asia. She supported malaria programs by providing strategic input, technical assistance. She has actively supported the establishment of M&E, or monitoring and evaluation systems, that enable better, timely alert and response activities, as well as strengthening surveillance in the greater Mekong subregion, a number of countries there, and then more recently in Mozambique, which is where I believe we will hear about today. So Arantxa, please go ahead, and I will progress your slides.
Thanks very much, Anna. And just to say that this is a pleasure to be part of this very relevant session today. And as the slide shows, I would like to kind of give a bit of a brief introduction of a case study of how we have been utilizing the geospatial data to inform potential next steps for in identifying targeted interventions in Maputo City in Mozambique. Next, please. So the content of this presentation really is just to give you a bit of a background on why Maputo City is really transitioning into very low transmission and exploring urban malaria as kind of a particular component for their national strategic plan. We will be looking at sort of how we have been using more granular malaria information and to inform specific targeted interventions. And I'll discuss briefly on some key findings and lessons learned, as well as some next steps. Next slide, please. So just a bit of the background. The Mozambique, which is shown on the map on the right-hand side, experiences a very high level of heterogeneity with regards to malaria transmission. So the map shows kind of the prevalence, which is kind of very heterogeneous, as I mentioned, with very high transmission in the middle, kind of central and northern regions. But as you see also kind of on the graph, specific areas in the south of the country, it's kind of looking at significant decreases of malaria prevalence over time. And particularly Maputo City is now experiencing less than 1% of malaria prevalence. So this is relevant for the topic of today on how we are supporting countries that are in the general kind of burden reduction sort of phase, but also experience areas that are transitioning towards elimination, and how routine surveillance systems can be adapted to inform those elimination strategies. So next, within that context, the National Malaria Control Program kind of went through a process of strengthening surveillance components to kind of ensure that the data quality, data use, and data to action sort of components were tailored to and effective to all the different transmission intensities and all the different intervention needs. The purpose of this particular geospatial kind of assessment really was to assess the spatial and temporal trends in malaria cases that were being seen in Maputo City, to identify areas where transmission is still local or likely to be endemic versus others that were likely to be due to importation. And with that, to provide recommendations of future implementation and improvements for surveillance in the elimination context. Next slide, please. Just a bit of the methodology. So this whole approach was really trying to adapt the programmatic use of the current surveillance system to be able to be more efficient or include more information, more granular information in the elimination very low transmission context. So what we did was to really look at the health facilities in Maputo City and introduce the case notification forms, which were paper-based initially, that collected information on the demographic information as well as travel history and place of residence. And that place of residence was aimed at a more retrospective exercise. So the place of residence or the closest point of interest was recorded on the form and then looked into Google Maps to identify that geolocation. In terms of data analysis, what we looked was more of a very initial descriptive analysis, looking at the effectiveness of the programmatic data in terms of allowing us to identify potential areas of residual transmission with visualization of trends data, missingness, and the geospatial components. Next. So the first element really, which I think it's important to point out, is that whenever we do an adaptation of a routine system, it's important to know to what extent it's sufficiently collecting all the new data. So one of the first things we did is to look at the missingness of the information. And this diagram really shows the distribution of the missingness of data across the kind of case notification form and across all the different health facilities. We collected around 2,000 malaria data from malaria patients of confirmed malaria from November 2019 to August 2021. And the exploratory analysis conducted to assess trends in the data was looking at the missingness to characterize the programmatic nature of that data collection. The use of, obviously, as you can see from the figure, the use of paper-based questionnaires resulted in some missing data. However, we did not see a distinct pattern in the missingness from the data that had geospatial information versus those that didn't have, that will allow us to continue with a much more geospatial and temporal analysis, which I'll show in the next slides. Next. This next slide really shows the age distribution of the malaria cases and by gender, which you can see in different colors, and in yellow being males and the darker colors females. But also that distributed according to the travel history, whether it's those that did not travel during the previous month versus those that travel in the previous 4 weeks. And around 65% of the reported cases traveled, which could be an indication of potential infections that are imported into the city. And we wanted to look specifically at that particular subset. It's also interesting to note in this slide that the age distribution of cases was similar regardless of the reported travel patterns. And we see that the majority of the cases were observed in the young children and working age adults. And that was something in a way not expected, as we expected potentially under fives being a potential proxy of local transmission. Next slide is really showing the geospatial distribution of the cases. Is the number of cases per borough. In this case, shows that the borough is the lowest administrative level, like neighborhood, and also how that relates to the travel history and the reported travel. So only 55% of the cases were successfully geolocated and mapped to the closest point of interest. In this geolocated subset, maps of the burden of the number of malaria cases at the neighborhood level, at the borough level, show that the cases distributed across the different areas of the city, but showing a higher burden of malaria in the northeastern virus. And this burden was consistently across the different seasons, which I'm not showing on these slides, but also when compared among those that traveled to those that did not travel, there was kind of a different pattern observed. So for example, when you look at the right-hand side graph, in virus in the southwestern part of the city, the majority of the cases geolocated in that area reported traveling in the last month, and which might be an indication of potentially not a significant local transmission in that area. Next slide, please. The burden, as I was saying, tended to be concentrated in the northeastern parts of the city. But that was consistently higher relatively to the rest of the virus or the rest of the neighborhood areas in this, across all the different transmission seasons, as you can see on the kind of distribution by month and on that next slide. And there was no differences observed in cases reported recent travel during the high and low transmission seasons. Next slide, please. This last slide in terms of geospatial analysis shows how collecting more granular spatial information of place of residence increases the analytical power to observe trends in a given catchment area. So the first figure, figure A, shows the location of the health facilities, with both the size and the color are represented the number of cases reported per health facility. So it gives a sense of an initial sense of where cases are concentrated. If we look at more granular information, which is shown on figure B, shows that the location of the health facilities, which are the black dots, with the size of each dot represented the number of cases reported, but also with the color of each neighborhood area represented the number of cases reported that resided in each neighborhood. And that's beginning to give sort of a higher level of information with regards to distribution of cases. And obviously the most granular option, which it's shown on figure C, shows the location of the health facilities, again on black dots, but also with the cases geolocated down to the household location. So there are different spatial information needs that will facilitate different levels of analysis of potential assessments of the patterns observed, which have been really kind of the purpose of the specific study to really understand what will be the optimal improvements that will facilitate decision making in this particular urban setting. Next slide shows just a summary of the key findings, and that really describes that there is significant missing data, but additional data collection provides a more granular overview of those spatial trends and how the incorporation of the digital collection of data will support the minimization of the missingness of data. On one of the key next steps that are going to be sort of being looked at the national program is really to start looking at those particular northeastern virus to specifically collect entomological surveillance information to better understand the vector dynamics in those particular areas. And the next slide just really shows the recommendations from this rapid assessment that looks at looking at what are the minimum epidemiological data elements that will be important for countries that are looking at transitioning from aggregated to case notification information, especially at the geospatial level. What are the options that might be relevant as a transition? So we could have the nearest landmark, it could have the neighborhood or a kind of the lowest administrative level. And I think one of the key recommendations from this group, it's we've been sort of looking at although there might be benefits of obviously looking to the lowest granular level, collecting household level data could be potentially quite cumbersome from an initial first step for transitioning into case notification and elimination practices, and maybe just getting information down to the neighborhood area for the first initial decisions that need to take place for recommended targeted activities of surveillance or interventions might be suitable from a programmatic perspective. And just a recommendation that, again, looking at how the digital data collection platforms could facilitate and accelerate those processes. I think that was one of my last slides. Just the next slide is just to thank again everybody that contributed to that piece of work, the NMCP and Mozambique, Dr. Candrino, Program Manager, the Malaria Consortium team, and Dr. Gillian Strassman that led the analysis of this piece of work at the London School of Hygiene and Tropical Medicine. Thank you so much.
Thank you, Arantxa. That was fantastic. And I really appreciate your recommendations and how you're thinking about, you and the team thinking about degrees of scale and how that's going to be most pertinent and relevant within operations. Let's move on to our last speaker, and then we'll pause for panel discussion. Dr. William Moss is the Executive Director of the International Vaccine Access Center, as well as the Deputy Director of Johns Hopkins Malaria Research Institute at the Bloomberg School of Health. Dr. Moss is a pediatrician. He has a subspecialty training in infectious disease. He's worked across Africa and India, among other countries. His broad research interests are epidemiology and the control of childhood infections in resource countries. A specific focus has been HIV epidemic on measles control and eradication. I know I could go on, but Dr. Moss, really appreciate you being here as well. I really respect your work and looking forward to hearing more.
Great. Thank you very much, Anna, and welcome. Greetings to all the participants. It's my great pleasure to participate in this really fascinating symposium. What I'm going to do is give very briefly 2 case studies of problem areas, so areas that are further away from elimination than what we've talked about before. The work that I'll be presenting is work done by a large group of people under the Southern and Central Africa International Centers of Excellence for Malaria Research. Next slide. So the Southern and Central Africa isomer works in 4 areas, but I'm going to focus on 2. As in Mozambique, Zambia has heterogeneous malaria transmission with quite low prevalence, moving toward elimination in the southern part of the country, but very high transmission in other parts of the country, including in Chilenge district in the north, and I'll talk about that. One of our other isomer sites is Mutasa district in eastern Zimbabwe on the border with Mozambique, and I'm going to talk about how we can leverage geospatial data to better understand cross-border malaria transmission. Next slide. So we'll start in northern Zambia in Chilenge district, a region of high transmission, really holo-endemic malaria transmission, meaning year-round malaria transmission. And we want to leverage geospatial data to understand why the standard package of interventions for malaria control have had a limited impact. Next slide. So this slide, the figure on the left shows a time series of parasite prevalence extending from 2012 to 2022, so over a 10-year period. The bars running across are different rounds of indoor residual spraying with different insecticides. And then vector abundance is shown in the dark purple at the bottom. And what I want you to take away here is that despite repeated rounds of indoor residual spraying, parasite prevalence, as shown here, as well as malaria incidence, has remained very high. We haven't seen a large impact of the indoor residual spraying. On the right is a map using satellite imagery as the background of the initial targeting of indoor residual spraying in this district. The blue on the left is Lake Mweru. So this district abuts Lake Mweru. And indoor residual spraying is a highly labor intensive and expensive process. And so the initial rounds were targeted largely along the high population densities along the lakeside with some small interior areas. And what I want to show you in the next slide is how we can leverage geospatial data to guide both the timing and the spatial extent of indoor residual spraying or other vector control strategies for malaria. On the left, I'm showing you spatial risk maps, and these were generated in a way analogous to what Anna described at the beginning in her introductory remarks about how one can leverage various layers of geospatial data to create risk maps to help guide programmatic interventions. And we leveraged epidemiological data from on malaria transmission from health centers and epidemiological surveys, as well as the remotely sensed data on vegetation index and water bodies to generate these. And 2 points. One is that the malaria risk extends throughout the district. And 2, it doesn't change too much from the rainy and dry season. And this has to do with the unique ecology of this area. On the right, I'd like to introduce a different type of geospatial data. That's geospatial data generated using GPS loggers, where we were able to track individual movement patterns from the lakeside into the interior. And basically, this showed that people were moving very frequently from their farms in the interior to the lakeside for fishing, even within an individual month. And both of these findings kind of together suggest that indoor residual spraying in this area really needs to target a much wider part of the district rather than just the lakeside. And as we're currently working with PMI now on assessing indoor residual spraying applied at the end of the rainy season rather than the beginning of the rainy season. Next slide. One can also use the spatial distribution of cases that are hospitalized, of children hospitalized with severe malaria, to better understand where resource needs are and what some of the challenges are or factors contributing to increased malaria mortality. And just very briefly, this slide is highlighting the relative case fatality of severe malaria among children hospitalized at the main district level hospital there, and showing increased mortality in children arriving from the Montepala refugee settlement and from a community that's some distance away from the hospital, indicating the need for better resources to reach these children and treat these children earlier or transport them to appropriate healthcare facilities. So again, leveraging geospatial data to understand patterns, spatial patterns in malaria mortality. Next slide. I next want to very briefly move to Matassa District on the border with Mozambique. Next slide. This shows health facility cases, passive case detection for malaria, similar to the slide I showed earlier for Chilenge. The bars represent different rounds of insecticide. And what we saw was that the malaria burden went down with the introduction of Actelic IRS, but kind of stayed high and even increased more recently and then dropped off. And we're still trying to understand that drop off. But I also show in gray here patients from Mozambique, self-reported from Mozambique. And what we wanted to do is understand how these patients from Mozambique are contributing to malaria transmission in eastern Zimbabwe. Next slide. So this again is a map of Mutasa district in eastern Zimbabwe, again showing that similar malaria risk map that it leverages multiple geospatial layers of data, as Anna outlined earlier and I just described for Chilenge. And what you can see is that the malaria risk is higher right along that border with Mozambique. Now, there are other changes here. There are changes in elevation. The elevation drops that are also contributing to this high risk along the border with Mozambique. Next slide. We also used the GPS logger data or study in Mutasa district in Zimbabwe. And again, you can see using these GPS logger data that there's very frequent movement across the border. And we were able to leverage this logger data as well as with more sophisticated statistical models to really enumerate or quantify how much cross-border malaria transmission contributes to the malaria transmission in eastern Zimbabwe. And just to give you an example, the risk of malaria increased by about 160% for people who reported overnight travel to Mozambique. So just in summary, geospatial data can be used to understand reasons for persistent malaria transmission. Despite adequate control measures, one can generate spatial risk maps, one can understand human movement patterns, and one can use those human movement patterns and spatial risk maps to better quantify cross-border malaria transmission. Geospatial data can also be used to identify factors contributing to malaria morbidity and mortality, and all of this can be used to inform programmatic interventions. And I'll stop there, Anna.
Thank you so much, Dr. Moss. Really appreciate that. I think that we've had some fantastic examples here from various malaria transmission areas. We've got the elimination areas. We have some challenging areas that Dr. Moss just shared. Could everyone on the panel go ahead and turn your video on? We just have a couple of minutes for a discussion, but I think a couple of relevant points I want to bring and just get some feedback on. We have heard that geospatial data is important in a number of environments. Would someone like to just give a general comment on their thoughts of the use of geospatial as we progress from challenging and control environments to more elimination environments, and your thoughts there and where that tool fits?
I can start, but I'm sure my colleagues can add. But just I think one of the most important points is that I think as countries or communities move toward malaria elimination, the need for finer and finer resolution of the spatial resolution of the data is really important, because you're really in the elimination setting, you're really trying to get down to small clusters of transmission and these small hotspots. So I think in part the spatial resolution of the data needs to get finer and finer in the elimination settings, as was shown for Maputo. Yeah.
Absolutely. And related to that question, Kafula, Aransha, or Matt, what are you thinking in terms of how do we move this field, which in some cases has been somewhat academic, to more operational, getting that more granular data operational within a health information system, actually working in the country? What are some of the steps along that roadmap that we need to be looking at as a community?
I could start. I think one of the key steps would be to ensure that capacity is built within the programs, the programs that interact daily with this sort of data in terms of data management. So the more tools that are being developed and the more diverse the types of platforms that are being developed, I think capacity within the programs, the national programs themselves needs to be built, so that at least there's interaction with the tools themselves on a much more regular basis to ensure that they're their own workforce develops the skill set that will be required to move ahead. And of course, resources are definitely going to be required with regards to investment in the gadgets that are usually used for this type of data collection. Thanks.
If I may add, and I fully agree with Kafula. I think capacity building is going to be a very critical component, and I think the sustainability element, it's also very important. So we need to consider integration of these new kind of tools and components as much as possible within the programmatic routine day-to-day activities. So if it needs to ensure that it's embedded into the practice, rather than creating a parallel practice that then creates conflict on the day-to-day. And I think that that's a very important element for sustainability, that it's a tool that gets embedded into the kind of activities that the health personnel or the National Malaria Program does.
Anna, maybe I can add, and I agree with my colleagues. I would also just like to emphasize the need for us to remember that the data shouldn't just flow one direction, upward from the local level that's generating the granular data up to the national level. It needs to be available at the local level as well, I think, for data validity as well as use.
Thanks to everyone on those comments. We have about 1 more minute, and we may get awkwardly cut off. I want to say thank you to each one of these panelists. This was a fantastic session. Like I said earlier, I really respect each of your work. Dr. Murphy, would you like to give one more kind of parting word, final comment, particularly around the roadmap and next steps from a global PMI perspective?
You bet. I mean, I completely agree with what's been stated by the other panelists today. And I think in a big picture, it's continuing to work with our local partners on the ground to get a lot of these new tools become more sustainable, is to reach out to the academic institutions, the other partners on the ground. I feel like sometimes there is a gap between what government's doing, what international partners are doing, what academia is doing, to really get to some of that granular data and to make sure we're using that data. And as Bill mentioned, to make sure that data is getting back to the local decision makers. This is important in any control setting, but also an elimination setting where each case becomes more and more important as we try to push towards elimination goals.
Thank you so much, Dr. Murphy. There are a couple of questions hanging in the Q&A. I see some questions about challenges of interoperability, how the GPS data were collected and whatnot. If you could go ahead and touch base there, if that touches your project. I would say for all participants, there will be a survey that you will receive after this session. And for ICT4D, please do respond there. So again, I want to say thank you. We are at time. Arantxa, Bill, Kafula, and Matt, again, really appreciate your work. Looking forward to hopefully further collaborations and discussions here, a longer discussion than 7 minutes. Take care, everyone. Bye-bye.
Thank you. Bye-bye.
Thank you. Welcome. Bye-bye.